Hello, thank you. Thank you everyone for joining us this evening. I'm Dr. Charles Liu. I'm a senior member medical oncologist in the Department of Thoracic Oncology here at Moffitt Cancer Center. Uh, Thank you so much for joining us. We have an information-packed webinar tonight, and I'm confident you'll find valuable what my colleagues have to share with you. Before we begin, please be advised that the content is not intended to be medical advice, and viewers should consult their physicians should they have any questions. The viewers should not only rely on information contained in this presentation for immediate or urgent medical needs. Additionally, if you think you have a medical emergency, call your physician, go to the nearest emergency department, or call 911. Never disregard professional medical advice or delay seeking care because of information in this webinar. Again, we're so pleased to have you with us tonight. We'll share more exciting breakthroughs throughout the evening, starting with our first speaker. Before I introduce him, I want to remind you that after we hear from our speakers, you will have the opportunity to have your questions answered by these experts. So we invite you to type your questions into the Q&A box located at the bottom of your screen at any time. Now on to our first presentation. I'm pleased to introduce Dr. Lary Robinson, a thoracic surgeon here at Moffitt Cancer Center. He has been at Moffitt for 30 years and has been instrumental with initiatives in lung cancer screening and prevention. Dr. Lary Robinson, please take it away.
Thank you, Dr. Liu. Thank you for inviting me to speak this evening. I'm going to spend a few minutes just talking about early stage lung cancer. Lung cancer, as many of you may or may not know, is an extremely deadly problem. There's at least nearly a 250,000 new cases yearly in the United States and a couple million in the world. Unfortunately, around 130,000 people are estimated to die this year from lung cancer. That's about one person every 4 minutes. Just to give you some perspective, that's as if all the population of Gainesville, Florida died every year. So it's a large number of folks, and it's a terrible problem. The yearly deaths from lung cancer equal the next three cancers combined. And even if you ignore smoking status, 1 in every 16 patients or people will get lung cancer. And the thing that's really changed in the last, 15, 20 years has been the appearance of lung cancer in never smokers. In women, about 25% of the women who get lung cancer are never smokers. I see at least one a week in clinic. And about 10% of men are never smokers. We're not sure why that's the case. Other places in the world, like Taiwan, 60% of the people who get lung cancer are never smokers. So it's a very disturbing change in the epidemiology. Only about a quarter of the patients, unfortunately, are diagnosed early when the survivals are highest. If you look on the right side, you'll see that the early stage cancer survival rate is at least 70% at Moffitt. It's higher than the national average. But as you get more advanced, the survival rate at 5 years goes down. Next slide, please. The only thing that we've found reliably with a number of studies to find lung cancer early is low-dose screening CT scans. And we've known this for nearly 10 years now. The eligibility criteria that we've developed over the years, and this is the United States Preventive Service Task Force, the recommendations, the most recent ones, are that people who that are considered high risk, if they're over the age of 50 and have at least a 20-pack year history of smoking, 1 pack a day for 1 year is 1 pack here. And then those who are either currently smoking or who have quit in the last 15 years. Now, in the United States, that's about 14.5 million people eligible for screening. That's more people than reside in the state of Pennsylvania. If we could theoretically get all of those people to have a screening CT scan, we'd find about 150,000 new cases, and we'd save about 80,000 lives every year. This is more than twice the number of people who could be held in the Washington National Stadium. Unfortunately, our screening CT scans have not been taken up well in the United States and in Florida. For example, those who are eligible for screening for breast cancer, about over 3/4 of the women who are eligible for screening for breast cancer get their mammograms. Colon cancer, at least 2/3, as you can see down the bottom. And it's about 5.5% of those eligible for screening CT scans get them done. Next slide, please. Low-dose screening CT scans is very effective. As you see, it takes about 320 screening CT scans to save one life. Breast cancer, it takes about 1,500 mammograms to save one life. And it's far cheaper. If you find stage 1 lung cancer, it costs very little compared to advanced stage cancer. And these numbers on the right-hand side are probably old, and they've gone up, obviously, with inflation. Next slide, please. What are the reasons why people aren't getting screened? Well, there's a number of reasons. The physicians always say that people have a fear of finding lung cancer, or they're a fear of discovering benign incidental findings that require some monitoring or at least some invasive tests. There's a shared decision-making that's necessary where you just need to just talk with the patient. An APP can, now even a nurse can, and just make sure that they don't have any symptoms and they've had no previous CT scans and that they understand the risk of doing this. Patients are concerned about radiation exposure, but the radiation exposure from a screening chest CT scan is about half of what you get every year just walking around on Earth. You get cosmic rays, you get radiation from the sun, so it's an insignificant amount. They're concerned that insurance won't cover the screening. And by the Affordable Care Act, all insurance companies are required to cover the screening in addition to Medicare if you meet those criteria. But one of the reasons the patients always say it's because no one asked them about it, and the physicians frequently will not recommend them. And particularly in rural areas, there's a lack of availability of appropriate imaging areas. Next slide, please. To focus on that last problem, we are very excited that we just recently received our mobile lung screening CT scanner. This, as you see, is a beautiful device. It's the second one in the United States, and it's going out for its first visit in about 2 weeks in Pasco County. We're going to follow the screening guidelines and people will arrange to have their screens beforehand. The people going out, this is a completely self-contained unit. It has this mobile generator. This truck, we call a mobile unit, essentially just pulls up, puts down something to stabilize it, turns on the lights and opens the door, and you're ready to go. We anticipate doing at least 6 to 9 patients a day. You can do a maximum of about 15 patients a day. It takes only about 15 minutes. People are pre-registered. They arrive a little early, sign in, go have the screening CT scan. The screening CT scan takes about 30 seconds on the table. And the patient enters the unit, gets the screen, and walks out the other door. So it's a very efficient process. And the only people who go along the screening team is a bus driver, the CT tech, and the registration specialist. Next slide, please. This is what it looks like actually inside. It's about half the size inside of a small 1-bedroom apartment. You see the CT scanner on the left. The registration is a separate room that you see in the middle. And this just shows you the back of the vehicle, which has a generator on it. These are much more efficient than other units that have been designed in the past, which are semi-trailer trucks, which required a separate generator. It had a difficult place had to find a pad. It was quite cumbersome. This is a very, very efficient unit. We're very excited about it. And like I say, it'll be going out in about 2 weeks. Next slide, please. The important thing is when you find something positive, you need to do something about it. And you need to have the patient seen if they have a lung nodule to be evaluated. And you need to be evaluated by someone who actually knows what's going on, because a lot of providers out in the community aren't sure how you evaluate a lung nodule, what you need to do, and don't follow the guidelines. So we've set up the lung nodule clinic, which I run, and it's dedicated to find patients who have lung nodules, who might have lung cancer, and are potentially curable. They don't need a definite diagnosis to be seen. It's a referral source for internists, family practice, pulmonologists, oncologists, and so on. And what we do is we assure the providers that the nodule clinic will take responsibility for the evaluation and follow-up of the patient's nodule. And many times it requires a lengthy follow-up that many of the providers out in the community don't really have the means or the method to be able to follow these patients, and they're concerned that they'll fall through the cracks. Yet that patient will continue to see his primary doctor for his hypertension and all the other problems. We're looking for patients who have indeterminate lung nodules found on screening CT scans or other CT scans. There's about 1.6 million new nodules found in the United States in patients. Unfortunately, about 2/3 of the nodules are not followed, and most of the screening guidelines aren't followed, so there's a lot of unnecessary tests. We offer a clinic visit within a week, and the follow-up can be frequently handled by virtual visits as necessary. Next slide, please. So this is our Lung Cancer Early Detection Center, which involves our screening program, our surveillance program, and lung nodule clinic. We've consolidated all this to improve our efforts to find lung cancer early. Next slide, please. If you want further information about lung screening, you can go to the website seen at the bottom. This is a brochure on the right-hand side that really goes through and explains everything about lung screening and why it's necessary. And then on the left side, it gives you more information, particularly about our Lung Cancer Early Detection Center in the 3 different clinics. So this is all available online. Next slide, please. And I thank you very much for your attention. And I think Dr. Aleyas will now give us a little information about how we evaluate these nodules when they need something invasive.
Thank you, Larry. Hello, my name is Savije Aleyas. I'll be giving the next talk. We'll be talking about innovations in the early detection and diagnosis of lung cancer. Next slide. So I'm going to give you a little bit of a background into what is a pulmonary nodule, how do we work up a pulmonary nodule, and a little bit about the latest interventions and innovations that we've developed for lung cancer to get an answer as to what these nodules are and to diagnose early lung cancer. Next slide. So when we find a lung nodule, how do we know what it is and what are the chances that this nodule or spot is cancerous? In reality, 95% of pulmonary nodules are not cancerous. So what else could it be? Well, here's a list of what else it could be. It could be a benign lesion like a lipoma. It could be infectious nodule. It could be inflammatory. We see this often in rheumatoid arthritis. And it could also be congenital, something that we're born with, or it could be a vascular growth. In reality, about 4 out of 100 cases actually turn out to be cancerous. Next slide. So how do we figure out which nodules are concerning and which nodules are not concerning? This is when we do a risk stratification of the pulmonary nodules. We're risk stratify the patient based on their risk factors, like Dr. Robinson was talking about, smoking, family history, secondhand smoke exposure, as also radon exposure. We also look at the CAT scan characteristics, the location of the nodule. We know that the lung is built with lobes, and on the right side, we have an upper lobe, a middle lobe, and a lower lobe. And on the left side, we have an upper lobe and a lower lobe. If the nodule is found in the upper lobe, we know there is a higher risk of lung cancer in that nodule. We also look at the shape of the nodule. A more irregularly shaped nodule is more concerning than a regular shaped nodule. And we also look at the size of the nodule. The size does matter in this case. When we look at the nodules, if you look at the bottom right chart, the column to the left talks about the nodule size, and the column to the right will talk about the risk that that nodule has of being cancerous. So if you could see, once we get to the 8 to 20 millimeter nodule size, the risk of it being cancer does jump up to about 15%. And over 20 millimeters, that risk does jump up to 75%. Next slide. So the challenges we have in early detection and diagnosis of lung cancer is in these 8 to 20 millimeter nodules, which are very tiny. And just to give you a reference point, you could see here on the slide, which an 8 to 20 millimeter nodule is roughly about 1 centimeter to 2 centimeters. That's roughly the size of a pea or a peanut. And the lungs is sort of built with airways, and those airways branch out into so many different branches, just like branches of a tree, and they get narrower and narrower as they branch out. So it becomes very difficult to find these little nodules within the airway. It's like a maze and almost like finding a needle in a haystack. Next slide. So this robotic bronchoscopy is the latest technology that we have at Moffitt, which really allows us to go after these smaller nodules, which we haven't been able to go after before. So you can see on the left, this is the setup for the robotic bronchoscopy that we have. All the way in the distance there, you can see the patient laying down on the operating table. The patient would be completely asleep under general anesthesia. And we have a scope that's a tiny scope. It's about a 3.5 millimeter scope, which has a camera and light at the end of it. And this goes down a patient's mouth, and we're able to navigate into the patient's lung. This scope is attached to a robotic system, which we're able to control with the console that you sort of see in the front there, that iPad-looking console with a stand. Next slide. So the scope, which has a camera and light at the end of it, is about 3.5 millimeters. So it's a very tiny scope, and it's able to navigate throughout the branches of the airway, allowing us to get through all these distal branches to be able to get to those smaller nodules. Next slide. So the doctor will be actually standing on the side of the patient and actually controlling the scope and controlling the robot with the console, that iPad-looking console on the side. And we'll be able to see within the patient's airways and also see the virtual image of the airways on a computer screen. Next slide. So this is a case that we had recently of a 54-year-old gentleman who had he had a left upper lobe nodule, which was about 1 centimeter in size. What we did was we took the patient's CAT scan. We were able to download it into the robotic system. The robotic system, using AI-like technology, will create a 3-dimensional image of the patient's airway, and also will give us a pathway that which we can follow to get to the nodule. That pathway is highlighted in blue. This pathway we'll be able to follow to actually get to the nodule, which is highlighted in the bluish green circle at the left top corner. Next slide. So this is what we'll see. It be a virtual bronchoscopic image, where we'll have a virtual image of the patient's airway, and we'll actually have a blue path to follow as we're doing the procedure to take us to the actual nodule. Next slide. So this is the case, and this is how we see it on the computer screen. To the bottom right, you'll actually see the patient's airway that we see through the camera. And on the left, we actually see the virtual image with the actual pathway so that we could sort of follow. It's almost like a GPS system like you have in your cars nowadays, that we could follow this pathway, and it will take us through all these branching points to get to the actual lesion. Next slide. So you can see we would navigate to the lesion, and once we get to the lesion, we see this on the left bottom. You'll sort of see this rounded circular greenish lesion. That's the virtual image telling us that we've gotten to the spot. And on the right, you can see the camera image, and we can see that little tiny nodule sitting in the airway. This was actually biopsied and turned out to be an early lung cancer, which we sent for surgery and for potential cure. Next slide. So the potential benefits of the robotic bronchoscopy, it allows us to get to these smaller lesions, which we haven't been able to get to before. And prior to this, we would have to watch and wait and sort of see if these nodules would grow. Now we could potentially pursue these nodules at an earlier date. And it's increased our diagnostic accuracy, as well as reduced our procedural risk. Prior to this, we would actually have to send patients for a CT-guided biopsy, which carries a higher risk than this procedure. So I'm very happy to have this, be able to provide this procedure to our patients at Moffitt. Thank you.
Well, just want to thank Dr. Robinson and Dr. Aleyas. Those are really informative presentations. I first wanted to take a moment to introduce one of our partners here at Moffitt, Mark Ketterer. Mark is with the Moffitt Foundation, and he partners with our thoracic program to ensure that we receive the research dollars we need to get clinical research off the ground and make advances in cancer treatments. If you'd like to learn more about how you can help, please contact Mark to find out more. At this time, Mark, would you like to say a few words?
Sure. Thank you very much. And thank you everyone for joining us this evening. And thank you to our esteemed panelists. The Moffitt Foundation is committed to supporting the research, cutting edge technology, and community outreach efforts in the Thoracic Oncology Department. You heard about our mobile lung screening unit this evening, and this was made possible by the generosity of Jim and Celia Furman. Philanthropy will continue to play a key role in the research outline this evening and the ability for our mobile screening unit to make an impact in areas outside of Moffitt's catchment area and within. Please reach out to me if you would like to learn more about how your philanthropic support can impact Moffitt's mission to contribute to the prevention and cure of cancer. And I look forward to moving on to the Q&A portion and hearing more from our panelists. Thank you.
Thank you, Mark. We appreciate all that philanthropy does to make research possible. Now, ladies and gentlemen, we invite you to ask any questions you have to our speakers tonight. Again, you can write them in the Q&A box at the bottom of your screens. I will read the questions and invite the faculty to answer questions that pertain to their areas. I'll start to look at the questions we have in our box. I think I'll start with there is one question which I'll have Dr. Robinson at least make comments on. The question is, or the statement is, the screening criteria mentions current smoker or someone who has quit within the last 15 years. What is the significance of the 15-year threshold? And the question is, should that be, is that an important threshold? I mean, is it something where it makes sense?
Oh, that's an excellent question. And the answer is probably should be removed. Actually, the American Cancer Society and the NCCN, which is the National Comprehensive Cancer Network, which also has our guidelines, have already removed that, since the risk for lung cancer doesn't just stop at 15 years if you've been a former smoker. That's still maintained by the United States Preventive Task Force, which initially came up with the criteria. When they started the initial studies to see if screening CT scans made a difference, they sort of arbitrarily came up with some ideas on who would be at increased risk. And they looked at, for example, increased risk of lung cancer sort of starts at age late 40s to early 50s and really goes up from there and peaks in the 70s. So this was a reasonable criteria over the age of 50. The pack year history of smoking, 20 pack years, that's significant amounts. That's actually came into play, and that's now being really questioned because it turns out it's probably not the intensity of the tobacco use, it's the length of time. So this probably should be changed to 20 years and not 20 pack years. And the 15-year criteria, that's become a real point of contention that we're really trying to get removed. And like I say, the American Cancer Society and the NCCN have already removed that. And for the Moffitt, by the way, Moffitt's mobile screening, we've taken out that criteria. So we're screening folks who do not, who haven't, it's not the 15-year criteria is gone.
Thank you, Dr. Robinson. Looks like we have more questions coming in. Let's see. I'll answer one of the questions. Was specifically asking about research in small cell lung cancer and immunotherapy. I'll briefly touch upon that. Just as a medical oncologist, I would say that immunotherapy certainly has made major inroads in non-small cell lung cancer, but also in small cell lung cancer. So I'll at least comment that we are now standardly combining immunotherapy with chemotherapy for small cell lung cancer in both advanced stages and more earlier stages. But I don't know if I could give a comprehensive question answer just in the period that we have. But I will say the answer is yes. Another exciting development regarding immunotherapy is the approval of a drug called tarlatamab, which is a class of immunotherapy. We call it a bispecific T cell engager, but it tries to get T cells in proximity to small cell lung cancer cells. So it's a great question, and immunotherapy definitely is making crossroads into small cell lung cancer therapy, and there's certainly research that is occurring in that area. There's one question regarding it's a surgical question, so I think it's maybe they're seeing if Dr. Robinson has some comments on it. The question is, what is the long-term effects for patients who receive parietal pleurectomy and talc pleurodesis? And the question is effects on restricting breathing or effects on breathing.
Well, a parietal pleurectomy and talc pleurodesis is obviously usually almost invariably done for cancer, usually either for mesothelioma or someone who has spread of the cancer to the lining around the lung and they've had recurrent pleural effusion, but mostly mesothelioma. So we know that a talc pleurodesis will cause scarring. That's why it's done, in addition to the pleurectomy. And that's to keep the lung re-expanded against the chest wall so fluid doesn't reaccumulate and collapse the lung again, which is a very significant problem and causes a lot of shortness of breath. Now, if you cause scarring on the inside of the chest wall, basically the pleura, you will get some restriction on breathing because the chest, normally when you breathe, the chest expands and gets larger and allows you to breathe in. So on that side, it will decrease your breathing. But on the other hand, or your ability to breathe on the side that you have it done. On the other hand, it generally will prevent the fluid from coming back, which keeps your lung expanded. So, it's a double-edged sword. The benefits and the downside is that you may not be able to breathe quite as well after a talc pleurodesis, but the upside is it will keep your lung expanded, so your breathing will be much better. So, I like to say any treatment has its risks and benefits, but this is only done, a parietal pleurectomy and talc pleurodesis is almost invariably done just for mesothelioma.
And Dr. Robinson, there's another question regarding screening. The question is, if non-smokers are increasingly diagnosed, with lung cancer, when do you expect that non-smokers could potentially be included in some type of screening? A very interesting question.
Well, this is a problem that we've been considering. A lot of us have been talked about. Who else should be screened? First of all, the numbers. There's about 230,000 new lung cancers diagnosed every year in the United States, and we'll just keep it in the United States. If we had all of the people who get screened, who are eligible to get screened with the current criteria, we'd find around 160,000 new lung cancers. In other words, you'd find about 60% of the lung cancers. That means 40% of the lung cancers aren't going to be in that group. And a lot of those will have other risk factors. We have a number of risk factors. As a matter of fact, in that book that I have on screening, I've listed all the known risk factors. Probably the major risk factors we're concerned about are those if you have a first-degree relative, that's mother, father, sister, brother, or a child of yours who has lung cancer, particularly early in life, your risk of lung cancer goes up, ignoring all other factors involved. For reasons we don't understand, if you're a female non-smoker, but you have Asian origin or Asian in your family, then you have an elevated risk of lung cancer. So that's a couple different types of problems. If you have heavy radon exposure, a lot of industrial exposures can increase your risk of lung cancer. So who should get screened outside of these risk categories? Well, that's something we're trying to answer. Probably if you have several of these and you're over the age of 50, you should consider getting a screening CT scan. Now, you might have to pay for it on your own because the insurance companies are not going to probably, if you don't have any symptoms, any other problems, they probably won't pay for it. And Moffitt is aware of that. So we offer a screening CT scan to people who don't meet that criteria, and they can pay out of pocket $170, which I often tell people that's about the cost of a family of four going to have a nice meal out without wine. But that may be something you might consider. You just need to have your doctor write a prescription for a screening CT scan. But who should be definitely urged to have it? We're not sure about that yet.
Okay, thank you. We have a growing list, so let's see. The one question is, it's a very broad question, so I'll just, there's a question about, are we commenting on the research that we're doing for non-small cell lung cancer treatment? So that one I'll have to at least say that's the answer is absolutely yes. I mean, non-small cell lung cancer, it includes 85% of our patients. So that is the largest group, and there's tremendous amount of research going on in many different categories. I would say that would include immunotherapy, which a prior question had asked about for small cell lung cancer, but also a very long growing list of what we call targeted therapies as we get smarter and learn different drivers of different subgroups of lung cancer, including non-small cell lung cancer. We're learning about these different types of either gene mutations or gene rearrangements or fusions, and trying to develop and test drugs that are very specific for those. So I would say absolutely there's a tremendous amount of research going on there. And the next question is Moffitt involved in providing data to improve AI algorithms for robotic surgery? I'm not sure, Dr. Robinson, if you want to comment on the robotic surgery.
Well, the robotic surgery, of course, is changing all the time, upgrading, and our surgeons use it virtually all of the time. And most of them are consultants with usually Intuitive, which makes the major maker of robotic surgery equipment. And so they're involved in consulting on improvements, how to make it easier to use, more effective, and so on. So they are involved in that without a doubt. Now you got to remember, robotic surgery just means it's not a robot that's doing your surgery. A person is controlling it completely. And all it means is that the person is at a console, the surgeon's at a console, and he's able to control robotic arms, which have they have a lot of dexterity, and it goes through small incisions in the chest. So it's not like they have a robotic program that's doing all your surgery. Is that going to come? Have no idea. In the future, that's going to be quite a ways. I think probably nobody here is going to actually see that, where, like you see on Star Trek or some other kind of science fiction. So robotic surgery is here, but it's still done by humans. It's just done through small incisions, and the surgeon has three-dimensional vision, has excellent visualization, is able to do things that they couldn't do with just plain thoracoscopy and so on. So it's being done, it's being developed, and it's being improved, but it's not AI directed itself.
Thank you. Next question I'll take a crack at. It's asking, is a PET scan good for checking cancer of the lung rather than taking a biopsy? Well, I'll say PET scan is imaging, just like getting a CAT scan. It does provide extra information. I tell patients it's looking at increased glucose. The typical tracer is fluorodeoxyglucose uptake, and where that is above normal background. But I tell my patients three things can cause that: cancer, infection, or inflammation. So when you have an abnormal PET scan, generally you still have to confirm that. So it's a very useful imaging, but it does not replace biopsy. Next question is a pulmonary, sounds like a pulmonary logistic question. It says, until now, I have heard that pulmonologists on staff at Moffitt were only available for inpatient usage or care. And when did they become available for outpatient?
At this time, we're available for inpatient care, but outpatient care for evaluating these cases that require robotic bronchoscopy or any kind of intervention. We're actually limited to that at the moment, but we're hoping to expand soon.
Yeah, and thank you. There's a next question. can this new technology also be used for stage 3 or 4 lung cancer to get a better view? I can at least comment on that because I know as a medical oncologist, I think the power that Dr. Aleyas' team provides would be ability to diagnose at an earlier stage smaller nodules or biopsying lesions which were difficult before. So my sense is for already an established diagnosis, like stage 3 or 4 lung cancer, then you probably wouldn't put the patient through those robotic procedures because they're I think mainly useful in my mind for early detection. Dr. Aleyas, do you want to comment or?
Yes, it's useful for early detection, but we can also help stage the patient with some of these minimally invasive procedures, which could help guide the oncologist on the best treatment strategies. And so in that way, some of these procedures are helpful in the later stages to help stage them properly.
Thank you. Next question is screening recommended for immediate family members of a person diagnosed with a non-smoking lung cancer?
Again, that's a real question that comes up. If, and I see this from time to time, I'll have a woman comes in, she's 65, 70 years old, maybe a never smoker, and she's got lung cancer. And of course, her 2 daughters are with her. And the first thing they ask is, should we get a screening CT scan? Well, they are at elevated risk. If they're non-smokers, they're still at elevated risk. Now, is that enough of a risk? We should have them run out and get a screening CT scan right away. We discuss that. I tell them that if, for example, if mom particularly developed lung cancer when she was early in her life, for example, 50, 55 years old, the risk we would know is significant there. 75-year-old lady who's her mother gets lung cancer and never smoker, there's still a risk. And I tell them they'll need to discuss that with their family doctor. And if they're over the age of 50, they may wish to essentially go out and pay for a scan themselves. And again, this is a problem that we dance around all the time, who to tell. And if mom is Asian and is a never smoker, then the risk is even higher. There was actually a study that just is being done in Boston where they take patients who are people who are Asian non-smoking females, and they've done screening CT scans now on almost 300 of them. And they've actually found more lung cancers in these individuals than they did in the screening CT scan trials. It's still only about 2 out of 100. So it may be that we may change some of those recommendations, particularly those with Asian ancestries. And again, we're not sure why that happens with Asian ancestries. That's the next question I'd ask. And anyone thinks we don't know that. But there's something about the cancers that they get that tend to run in families, Asian families.
Thank you. Next question was a question about how do I get the location of the mobile screening unit so I can get scanned?
Well, you have to go on Moffitt.org, and it has mobile screening, and there's a website there that tells you exactly where they're going to be setting up the units at various times. So you'll have to, I can't tell you, I just know they're going to be in Pasco County, I think at the health department, I think the second week in November. And but if you go there, you can find out exactly when that's going to happen, and you can register right there. But you'll have to go on Moffitt.org, and they can and there is a mobile screening section right there.
Thank you. Next question is similar to the other question. It's asking about can a PET scan can someone do a PET scan to see if they have lung cancer instead of a needle biopsy? I would say no. That you would need a confirmatory needle biopsy. There's really no imaging good enough that would take that place of the diagnosis.
Let me say one more thing about that, because I see a number of people with lung nodules, and they come in, they have a lung density of some kind nodule, and they get a PET scan. And out in the among most physicians, they consider a PET scan a cancer scan, and PET scan is not a cancer scan. I tell it over and over again, it's not a cancer scan. It's a scan for metabolic activity. So as Dr. Liu said, cancers can have glucose avidity and show up as a positive on a PET scan, or it may have very little uptake if it's a very slow growing tumor, and you can have a very hot nodule on a PET scan and to be an infection. So you really can't tell. And a majority of the people I see who have lung nodules of various kinds that have had a PET scan and have some glucose uptake, they're still benign. So you really can't tell for sure based on purely whether it takes up glucose on a PET scan. And actually, some of the hottest ones may be just a very active infection.
Another question is a screening-related question. It's a personal question. Someone, one of our lung cancer patients, is saying that they smoked for 30 years and quit 30 years ago, about a pack a day. When they were diagnosed with lung cancer, their GP, they asked their GP about screening, and he replied it was outside the standard of care. They're asking if that was accurate. Because the comment was that even if insurance wouldn't cover it, they may have considered paying out of pocket for that.
Well, initially that was it was considered if you didn't meet those criteria, you really didn't need to get a screening CT scan, even if you were a smoker and quit 30 years ago. Well, that's changed over the last few years as we've really seen the upshot of people getting lung cancer outside of those screening criteria. So the recommendations have liberalized so that if somebody doesn't meet the criteria, specific criteria, but is willing to pay for it themselves, if you ask your physician, almost every one of them will say, fine, and they'll order it for you, knowing you have to pay for it on yourself. But years ago, when this first came out, it was felt if you didn't meet that criteria, probably it'd be a waste of time. And we're not so sure about that now.
Next question is simply how often should one get scanned? So presumably, if they meet the criteria, it's asking how often.
Yearly. Should have one once a year. Some of those will develop just in that 1 year. So you can't just say I've had one and everything's fine, no problem. If you're going to start getting screening and you're eligible for those criteria, the recommendation currently is yearly.
Okay. Next question is I'll take a crack at this one. It's asking, is Tagrisso a chemotherapy or immunotherapy? So Tagrisso, or the name of the drug, osimertinib, is an EGFR, we call tyrosine kinase inhibitor. It's a pill that you take that targets EGFR, and that there are lung cancers that are EGFR mutant, and EGFR is driving the growth and spread of the cancer. So we generally classify any drugs that are targeting a specific gene mutation or alteration as, we use the term targeted therapy. So from a semantics point of view, we don't call it chemotherapy. We don't call it immunotherapy. We would call it, it would fall under targeted therapies for lung cancer. The next question is asking how are we using AI in either pulmonary or surgery?
Well, as I mentioned before, when they say robotic surgery, that means that you're directing arms somewhat apart from the actual surgical field. So the surgeon may be 5 or 6 feet away at a consult. So people get the idea robotic means there's going to be some machine that's doing everything, and it's not. The surgeon is directing the arms and the manipulation of tissue and cutting tissue and stapling and so on completely. It's not autonomous at all. So when you say AI, really AI is not involved in this. Same way for, well, I can let Dr. Aleyas say it, for pulmonary medicine or for pulmonology. I'll let Dr. Aleyas address that.
Yeah, just like Dr. Robinson was saying, is that right now we are still, it's sort of assisted by the robot. We're sort of assisted, but it's not an AI. We are, I believe, working on some AI models to actually detect these nodules and risk stratify them on CAT scans. In that way, we're working with AI. And it helps create some of the pathways that we're using, but not with actual procedural stuff at this point.
I should mention that, for example, our mobile screening unit has a CT scanner, which is really the sort of the state of the art from Siemens. And when you're in a mobile screening CT scanner that we have, as soon as your CT scan is done, the information is evaluated by a special AI program and actually locates any tiny nodules. And then this is automatically sent electronically to our radiologists, who then look at the CT scans and also look at what the AI, if you will, program has picked up. And so the CT scan is read very rapidly by the physician. So it's what we call AI assisted, just as Dr. Aleyas said. It's what they call supervised AI. So the AI might pick up some nodules and we'll look at them and try to figure out if this is something of significance or not. And it's supervised AI. It's not, again, autonomous, but it is being done. And this is the newest state of the art in CT scanning and screening CT scans. So we're very excited about this. And we're looking with a couple other companies to do this on standard CT scans that we're doing every day.
Thank you. Next question. Oh, this is a very tough one. It says, what experience has Moffitt had with LMD for lung cancer patients? So I would say, I say this is a tough one because LMD is an extremely difficult condition to treat. That's what we call leptomeningeal disease. And that's when lung cancer has spread through the circulation to seed the membranes around the brain and spinal cord. So that typically means when you withdraw spinal fluid, and that's the fluid that bathes, it's contiguous and bathes the entire brain and spinal cord, there are cancer cells in there. And it could be pretty devastating because of the neurologic effects on patients. So I will say that it's just an extremely difficult condition to treat for a patient. It's that person would have stage 4 disease, but it's extremely difficult to treat. I think I can think of a few situations where some targeted therapies have had modest success, meaning able to control it temporarily. But one of the challenges is getting high enough concentrations of the drug in the cerebrospinal fluid. But very, very difficult condition to treat.
Let me just mention something. I just saw the flyer for a seminar next week for a new Moffitt physician, Dr. Pina, who is specializing in leptomeningeal disease. So there will be some specialists, at least one here, for that difficult problem. I don't know what the status of it is. As Dr. Liu said, it's a difficult problem, but we have someone actually at Moffitt now whose specialty and her actual interest is and expertise is in LMD.
If I can jump in, I'm lucky enough to work with both the thoracic department and also the neuro-oncology department. And yes, Dr. Pina is amazing. She is highly focused on that area. And they work very well cross-collaborative, not just in their neuro-oncology space, but with cutaneous department I know of, with the thoracic department. So this is definitely something that is being worked on here at Moffitt.
Thank you. Next question is, for non-small cell lung cancer, is immunotherapy still the prime treatment? And I believe it's like not removal of the lung. I guess I would first say we always before we even talk about immunotherapy, we really will make recommendations for treatment based on stage. And so because if the stage is appropriate for surgery, then that still makes the most sense. Immunotherapy will not take the place of surgery, curative surgery. But immunotherapy in general for patients who are not candidates for surgery, although now they're making inroads and even giving chemotherapy, immunotherapy before surgery. So there's a lot of But in immunotherapy is still the mainstay that I would say for advanced non-small cell lung cancer. There is a lot of use of immunotherapy with chemotherapy, in some situations, immunotherapy alone. Let's see. Next question is, it said most new developments in medication therapy for lung cancer targets driver mutations or PDL1. What new therapies are available for patients with no driver mutations and PDL1 negative? So the treatments that are targeting those driver mutations, as I mentioned, that is correct. That as more driver mutations are discovered, then research, of course, is done into those newly discovered driver mutations. And then this large field of immunotherapy, which really tries to engage the immune system, often T lymphocytes, to attack cancer. So that is true. Those are two very large areas. And I would say if in the areas without driver mutations and that are PDL1 negative, I would say those are going to be the more difficult cases. But I would say even the PDL1 negative, that's not a perfect marker predicting what we call response to immunotherapy. So you can be PDL1 negative and still respond to immunotherapy. The chance is just less. So I would say there's research into what we call causes of resistance to that. And, there is a lot, as you mentioned in your question, about targeting PD1 or PDL1, but there are other targets for immunotherapy. So in combining immunotherapy. So that would certainly apply to a PDL1 negative patient. Next question is, are there prospective cures for stage 4 on the horizon? We always hope. I think we really hope that immunotherapy can or combinations of immunotherapy with whether even targeted therapies or chemotherapy, but can essentially allow us to control the disease for prolonged periods of time. Right now, I would say most of us would not be comfortable saying that we've got any drugs to cure that cancer that is stage 4. However, there are certainly, all of us have kind of exceptions to a rule of patients, usually, at least in my experience, who've had immunotherapy and unexpectedly have had very many years of disease control. So I think I couldn't really say we have curative drugs, but we're always hoping, and that's certainly part of the research that we're doing. Next question is, in reference to my non-small cell lung cancer question, it's about, is any research being done for patients who are not responding to treatments such as Retevmo? So I believe that's a question regarding, it's a question regarding if someone is on a targeted therapy. I believe in this case, targeting a RET rearrangement or fusion, and they develop resistance. I would say that we are always trying to do research in cases of resistance to targeted therapies. Many times, the first drugs that are developed are first generation drugs, but as the people in the laboratory learn about the mechanisms of resistance, they developed better drugs, more potent, or second generation, third generation. So that is usually a very common path of research for these when resistance is developed. Next question is, what about non-smokers getting lung cancer? Is there a long-term effect? I'm actually a little unclear about it just says, what about non-smokers getting lung cancer? Is there a long-term effect? Maybe I'll ask that person to maybe try to clarify that for us. Next question is asking if I treat patients with mesothelioma with immunotherapy. The short answer is yes. The most common medications or drugs that we are using are chemotherapy and immunotherapy. There are other classes, but I would say, yes, there are situations where you are giving immunotherapy for mesothelioma, and now some situations where you may even combine them. This is a patient at Moffitt saying they're a patient, Dr. Robinson, and I've had surgery twice to remove cancerous nodules. I'm scheduled to have a CT scan next month. Would I be a candidate for robotic bronchoscopy if a nodule were to appear, or would I need surgery because the other 2 times it was cancerous?
Well, this is something that people who have lung cancer once and who've been cured, they have an increased risk of getting a second primary. We say usually it's about 1 to 1.5% per year. That's why we recommend follow-up CT scans yearly for the rest of their life after they've had curative lung cancer surgery or whatever. Now, if you develop something new, it's not always cancer. People develop small areas of, particularly if they have some lung disease, can develop small areas of infection in the lung. I can't tell you how many people I've seen who've had a previous lung cancer, and there's concern they have another cancer, and it turns out to be an infection. So it doesn't necessarily mean you'd have to have surgery. The other thing to realize is that if you've had surgery several times, depending on where this, if you do have another nodule, and it does turn out to be an early stage lung cancer, then it's probably going to be very small, because if you've been followed along yearly with CT scans, likely if they find something new, it's going to be very early stage. And depending on the person's physiology, where it's located, what their lung function's like, we may or may not recommend a surgical approach. For small peripheral cancers, a very effective treatment, which we use for people who may not be the best candidate for surgery, but yet it's a localized disease, we have what's called stereotactic body radiation therapy, which is high-dose pinpoint radiation therapy, very effective, and it works with minimal side effects. It takes 5 treatments, 1 treatment a day, 5 days in a row. It takes about 30 minutes of treatment. So we use that for folks who may not be a candidate for surgery, who have a cancer, a tiny, small peripheral cancer. But like I say, if you develop some abnormality in your CT scan, even though you've had cancer before, it doesn't necessarily mean you have another cancer. In fact, I have a patient who I just called with the results of robotic bronchoscopy, and it truly was inflammatory, and we're just waiting to see what it grows out in culture. And they'd had a previous cancer before, and there was concern they had another one.
Thank you. Next question, it says, is for Dr. Aleyas. Is the technique of robotic bronchoscopy used to look at lung pleural nodules?
Well, if the nodules in the pleura, usually we don't need a robotic approach to get to the nodule. It's usually easier to go with CT guided or to do a surgical approach. If the nodule is within the lung, we can use robotics to approach that nodule if it's within the lung itself.
Great, thank you. Next question, if a nodule cannot be surgically removed, what is the first-line chemo drug used for non-small cell lung cancer? So I guess if it's been established that this is non-small cell lung cancer, I would say if for some reason a patient is not a surgical candidate, before we would talk about chemotherapy or drugs, we would want to at least then investigate. Dr. Robinson alluded to radiation or types of radiation, because those are still potentially curative. So for anywhere from stage 1, 2, and 3, we would still want to know, even if surgery was not recommended, if radiation-based treatment to try to potentially cure, would be an option. Now, if that's not the case, if you're talking about a stage 4 case, then I would just briefly say that our approach would be you first have to decide, is there a targeted therapy available? If there's not a targeted therapy available, then immunotherapy and chemotherapy are the most common combinations. The next question is, how often should the early screening be done?
If you're eligible for screening CT scans, you get an initial CT scan, and if it's negative, then a yearly CT scan afterwards. There's no reason to do it any quicker than that if you have essentially a negative scan. So about 25% of the people who have a screening CT scan who meet that criteria will have some kind of tiny nodule at least. And it turns out that of those, only a very small percentage actually turn out to be cancer. Overall, if 100 people who are eligible for screening CT scans get a CT scan, we find about 1.5, maybe as high as 2 cancers. And the others are just nodules that are tiny and don't need to be either need just a follow-up CT scan in a year or just need to be followed along, but they are generally not cancer. So it's basically yearly if you meet that criteria.
Next question is about the effect on diet on non-small cell lung cancer in non-smokers. I guess as Dr. Robinson alluded to, we don't even understand why non-smokers are getting lung cancer. So, but I would say certainly I don't think there's any compelling evidence that we would advise specific diets. So for a non-smoker or the effect of diet, as far as I'm aware of, for a non-smoker getting lung cancer. Next question is, can you elaborate on PD-L1 genetic marker? So PD-L1, we wouldn't refer to as a genetic marker. It is you might call molecular marker. It's a protein that you can test on tumor cells. And we generally use it to determine the likelihood of response to immunotherapy. Many of our immunotherapies are PD-L1 or PD-1 blocking drugs. So that's what we use it for. Another question is, do you prefer dual energy CT over low dose CT if available?
Well, low dose screening CT scans are just that. They're a very low dose to decrease the amount of radiation you get from it. So this is not a standard CT scan of the chest. It gives you a very nice look at the lungs, but it's still not a diagnostic CT scan. It's a screening CT scan. If you have a positive on the low dose, then they may do a more standard CT scan, which may involve dual energy CT scan. There's a variety of different types of machines, but for almost all low dose screening CT scans, they're not dual energy. I've talked to the Siemens people, as a matter of fact, when we got our new mobile unit, and that's generally not done with low dose screening CT scans. They do have dual energy, dual source. It's really called dual source. The CT scans where they have they get energy from 2 different angles, and it just really makes the CT scan go quicker and faster. But the current low-dose screening CT scans give you a very, very nice look at the lungs and really pick up things. They're considered to be well over 95%, or actually 97% sensitive in finding lung cancers.
Thank you. And the list continues to grow, but I feel badly, but I believe we've reached our time. So I was told at 7 o'clock, I think we're already over time. So, but I definitely want to thank our speakers, Drs. Robinson and Aleyas, and really thank our audience for very excellent questions. Really excellent, insightful questions. If you were unable to have your questions answered, please don't worry. I know there's a way that we'll try to follow up with you to try to answer questions for you. And otherwise, I think that will do it for tonight. Thank you all for being with us and taking the time. We hope you found this webinar informative, and we appreciate your continued support as we continue to work to try to revolutionize cancer care and provide the best possible outcomes for our patients. Thank you so much. Everyone have a good night. Thank you.